So now we're going to, we brought everyone back together. We have some questions from the chat and then a couple of other questions that Gunjan and I have prepared as well for you all. The first one that I would like to ask, this was one of the first questions that was asked. Scott, this one's for you. So there was, when you were talking about food and taking time, there was a question about how long to leave the food out. Bacteria can grow after 2 hours, but sometimes it can take that long for a person to eat. So I was wondering if you could give some tips for those longer meal times.
Yeah, absolutely. And I know that especially when you're talking about food safety and all of those types of things, people get really paranoid about that. And I understand for good reason they do. But there are obvious options that you can do. Sometimes you can actually take something and quickly reheat it in a microwave just to make sure that it stays at a decent temperature. And also simplifying the number of things that you're putting on the plate so that you don't have 5 options, but you only have maybe 1 or 2 options, so they're picking on those. And you're thinking of that longer term eating habit when you're putting those items on their plate. But, you know, I've watched residents over the years slurp ice cream. I mean, it's long since melted, but you know what? They liked it, and that was perfectly fine. So I'd be less concerned about all these safe food handling things and minimize what we put on the plate, and then focus on keeping what we need hot, and then do the rest as we can.
Those are great suggestions. Thank you. All right. And then and this is for all of you, whoever wants to go first. So is there any path for people to plan for their right to die or euthanasia? She states, I'm an RN and personally value quality of life over quantity of days. And then another person mentioned, I appreciate her question. Is it appropriate to stop providing the extra nourishment just to keep them alive when the quality of their life is no longer quality and their cognitive function is lost?
I'm happy to go first. In terms of the right to die, that I think it's tied up with the issue of medical aid in dying, which is not legal in Minnesota or North Dakota. It's legal in about 10 jurisdictions, 9 states and DC. So it's really, when I get asked about it, and I don't usually get asked it with regard to dementia patients from family members, that's uncommon, though they often will ask if we can, is it okay to stop feeding if mom or dad would have chosen to do this for themselves? I think the most important thing, again, is to make decisions that are consistent with what the patient would have decided, you know, for themselves. And the biggest issue are feeding issues in dementia patients, because at this point in time, we don't have medical aid in dying. Euthanasia is not legal anywhere in the country. It's legal in a couple of countries in Europe. So we're really dealing primarily with issues regarding progressive decline and nutritional decline and feeding issues. And I think that there should be orders written on every patient that's certainly a hospice patient, if not all patients with advanced dementia, that they should have comfort feeding only. In other words, if they're resistant to feeding, if they're choking, if they're not interested in eating, that they shouldn't have food continually pushed into their mouth. If they're taking food willingly and seem to be enjoying it and tolerate swallowing it successfully, then it's fine to assist them with feeding. But the focus again should be on the patient and making sure that feeding is comfortable for them. So we actually do write orders for comfort feeding only, but we have to educate the staff, because the staff is so focused on getting food into their mouths and continuing to empty the plate that they kind of ignore whether or not this is comfortable or at all interesting to the patient. In hospice, I tell part of comfort feeding is don't wake people up in order to bring them to a table to feeding. If they're sleeping peacefully, allow them to sleep. And when they want to eat and they're voluntarily eating and they'll take it voluntarily and it's comfortable for them, then that's okay. If they're choking, you shouldn't be putting more food in their mouth. And the other, let me just add one more point too, because this is a big item. Because and as Scott mentioned, you mentioned this in your presentation about supplements, and I've seen supplements used in addition to hand feeding, supplements are often used because, of course, they're an easy way to get calories into people. But I really do think that supplements, Boost and Ensure, and these should be an informed decision that the family should make. And the family should be asked, would your mom, would your dad have chosen to have supplements used to improve their nutrition and therefore prolong their life? Because many times I think the supplements, and I've been told this by many families, are contrary to the wishes of the family because they don't feel mom or dad would have chosen this for themselves. But it's almost an automatic in facilities that they shift to supplements when they're having trouble with feeding.
I would absolutely agree with you, Dr. Sandler. And I think the greatest pushback that I get as the, as a hospice medical director is from facilities.
Yeah.
It's not the families, it's the staff at the facilities. And so we spend a lot of time working with the nurses, the managers. I think their biggest concern is, well, is it legal? I mean, that I get that all the time. Is it legal? And then, the issues of we can't let them starve to death. And so I spend a lot of time with that. It's the emotional hurdles that I think people have the greatest struggle with. And I also have had some experience in that. I think it's much, much easier for people to not attempt the hand feeding and supplements than it is to stop it once it's been initiated. So I always try and address those issues as early as possible, because once it's in place and they stop it and then they see decline, they feel directly responsible for that decline. Whereas, I mean, we know that this is progression of the disease process, but it's just hard to assimilate, I think, that emotional component for a lot of the families and the caregivers.
I really don't have I don't have tons to add. First of all, I really would like to know where Dr. Sandler and Mallberg have been all of my life when I was working in communities and I had to fight these things every step of the way. So our audience today is privileged to hear two premier leading experts take advantage of this. Let me tell you, having worked in the environment where exactly what you're talking about, Dr. Mallberg, I mean, there's corporate edicts, and this is one of the complications of when you move a person from your home into a community. In your home, you are going to have greater, flexibilities and not a sense of liabilities. When you move them into institutional settings, they're concerned about liabilities. And so the nursing team has to document consistently and report on weight loss. And then that gets scrutinized because, of course, that indicates a problem. And I'm not going to take you into all of that mishmash of that, but that is an issue. And getting people to start to back off is not many times the family's problem, and would probably not be the residents' problem if they said, just please stop. My great-grandmother lived on coffee and chocolate cake for a year. And I can't think of a better way to go than that. But those are things you're going to have to wrestle through, actually.
Yeah, what I could like to, I agree with what Scott said, and I would just like to add that the regulation for monitoring skilled nursing facilities on weight loss is a regulation that they're graded on, but that is suspended when patients are admitted to hospice.
Absolutely.
So that's what a lot of times but they're kind of on automatic pilot, so they're used to this aggressive feeding to maintain weight of patients, and they don't shift gears when the patient goes into hospice. So they often have to be told this very explicitly. You're not going to lose points by focusing on comfort feeding approach for this patient if they lose weight because they're now in hospice. So let's just focus on comfortable feeding at this time.
Well, thank you, everybody. The next question is, when is palliative care appropriate? How do you go about receiving palliative care?
Dr. Mallberg?
Well, palliative care. So I loved, Dr. Sandler, you sort of used phrase that I use all the time, in that all hospice is palliative care, but not all palliative care is hospice.
Right.
And so the onset of palliative care can come whenever a patient has, I mean, in any disease process, not just dementia, but whenever they have symptoms. Now, the hard part for a lot of people is deciding, do I want to be all in the world of, just comfort and not treat anything, or do I want to be aggressive? And it seems very black and white for a lot of people, but that's not the case. I mean, there are situations where people want to continue to do some things aggressively. I mean, the example that comes to mind for me is macular degeneration. I mean, we have people with end stage, or very advanced malignancy and whatever, or even, dementia that's fairly progressed, but they're terrified, and they've always been terrified of losing their vision. And so then the family will continue with what are probably a little more aggressive treatments for that. And I think that's absolutely acceptable if that's within the wishes of the patient. But the hard issue for me, and has been for all the years I've been a medical director, was what happens to these patients that are very high need, but they have more than a 6-month life expectancy. And that I really struggled with when I first came to hospice. I battled with that sort of emotional kind of burden a lot, which led to us developing a home-based primary care program. Now, it doesn't come with all the benefits that hospice comes with. Our primary care team is not able to get CNAs in the house every day. We don't have chaplaincy and social work going out to visit on a routine basis. But we do have primary care coming into the home and helping with physical therapy in the home if needed, OT assessments, PT assessments, whatever, lab draws if they need to be. That's not available everywhere, especially in a lot of our rural areas. We try. I wish I had the grand answer for that one. I don't. But palliative can be initiated anytime there are symptoms that you want to mitigate, in a situation where there's not cure, or even if there is cure. I mean, lots of times we use palliative medicine in the world of cancer.
I think that there is a very, very high symptom burden in skilled nursing facilities as well as assisted living, but let's stick to skilled nursing facilities. And whether we're talking about dementia patients or patients with heart failure or patients with general frailty and multiple comorbidities, and these patients, most of them would benefit from palliative care involvement. The reality is we don't have the palliative care resources. There's not that many palliative care physicians relative to other types of physicians. There's not that many being trained. What I would suggest for people that are working with this population, even, pre-hospice, as Dr. Mallberg was referring to, because in hospice, of course, they're having palliative care focus. But if there's no palliative care involvement and no physician that can provide palliative care consultation, then see if there's an advanced practice nurse or PA that has palliative certification, hospice and palliative certification. Because if you can get that in your facility, that is going to help enormously in terms of improving the quality of life for this large group of patients that are very frail and elderly within skilled nursing facilities. And sadly, doctors, most doctors are very poorly trained in even what we call primary palliative care skills.
Yes.
Doctors like Dr. Mallberg and myself are called palliative care specialists, and that's consulting palliative care. Every doctor, in my mind, that deals with patients that have serious illness, whether it's cardiologists or oncologists or family physicians, should have a certain basic knowledge in palliative care, but they don't. most of the time, and that's very sad for patients.
Mhm.
Yes, I would agree. And we do have a palliative, a very small sort of palliative program in its infancy. And we have one certified NP. But to speak to exactly what you were saying, a lot of the providers in skilled facilities, when we offer to sort of provide palliative services, the response that we get is, what are you going to do that I can't do? And really nothing that you can't do. It's just that I don't know that they know to do. And that's a fine line we dance around sometimes.
Absolutely. So how does a person with dementia qualify for hospice if they don't have any other comorbid conditions?
Well, the foundation, Dr. Mallberg talked about this a great deal, but I just wanted to say that, this, the Medicare has certain criteria. Dr. Mallberg referred to the FAST scale and other areas that would indicate a poor prognosis. But I think that what people have to understand about Medicare is Medicare says specifically that doctors, the hospice physician, and the attending physician have to agree that the patient has less than a 6-month prognosis. And so in the case of dementia, if there is a patient that doesn't fit perfectly on the 7C category on the FAST scale, which is the identification that Medicare uses as a qualifying characteristic, but the patient is losing weight rapidly, and the patient is functionally declining, becoming much weaker, and the doctors believe because of that the patient has less than 6 months prognosis according to their clinical judgment, then that patient may be admitted to hospice. So the foundational criteria for all patients admitted to hospice, whether it's dementia or heart disease or cancer, whatever it might be, is a prognosis of less than 6 months. And because clinical judgment is allowed, then it should be used in patients with dementia, even if they don't specifically fit into the LCD, which is local coverage determination.
You're right, it is.
Even if they don't specifically fit into that, if the doctors believe the patient, because of their decline, clinical decline, has less than 6 months to live, then the patient can be admitted.
Absolutely.
And I would just simply add that I think coming from the inside of the institutional type of setting, I mean, I worked in Minnesota when I talked about the community where 80% were on hospice. I come to North Dakota and nobody is on hospice, Dr. Mallberg, as you just referenced. And I was like astounded because it's like, are the people in North Dakota much more robust? I mean, it looks like they don't live any longer. And so I've had people brought in on hospice. The shortest stay I ever had was 16 hours. And I'm like, I was so sad because there could have been so much. So part of it is working with your own physician to get them to move on this. It's not a difficult criteria to meet, believe it or not. In other parts of the country, it's almost standard practice where doctors say, I think this is the time to start having this conversation as a family. So part of it is we need to make a cultural shift in North Dakota is what I'm saying. It's not a non-availability, it's a ability to speak to the issue.
In the chat, someone is wondering, do you use the mortality risk index of Mitchell in your clinical judgment for the hospice benefit?
We use it at our hospice, Health Partners Hospice, as one of, and again, it's just one indicator. It can be quite helpful. It's a helpful indicator, but I like to look at things more globally in terms of what's happening to a patient. Are they, and again, it doesn't matter what their diagnosis is, but I'm looking at, in fact, their symptoms, if they have heart failure or COPD, I'm looking and the level that their symptoms occur, and also their nutritional and functional status. To me, the most important indicators are symptom progression, nutritional and functional decline. All those are important, but the mortality risk index can be a useful tool as well.
Yes, and I would agree with that. We use it as a tool, not exclusively. I do train all my nurse practitioners on it, and agreed. The look at the entire patient. I mean, I understand the question about advanced dementia in isolation. What does it take to qualify for hospice? In my experience, that's a tremendous rarity. I mean, we don't get that terribly often unless there's a really early onset of dementia, but very often there are comorbid medical conditions playing into it. Also, I take into account the trajectory of decline. I mean, if they're having really rapid decline for whatever reason, that can certainly play into it. One of the other comments I saw that came up was that somebody had commented that if they live past the 6-month life expectancy, that they can stay on hospice. And absolutely, honestly, if somebody gets a crystal ball and gets some way of being right more often than wrong, I'd love to know where that's at. I tell people all the time, I'm wrong all the time as far as life expectancy. The best we can do is pull together all the information that we have. And if their disease were to progress as expected, would they die in 6 months? I think so. I've had people on for a lot longer than that before, and that's okay. If they still have a 6-month life expectancy after having been on for 6 months, would I recertify them and keep them on? In a heartbeat.
So this question came up earlier on in the program. How do you abide by a POST form when a caregiver is in a restaurant with their person? What if they start choking? What if they have an outside caregiver with them and their wishes are different than the patient's POST form? How would you handle that?
Well, those are good, very good questions, and they're hard questions to answer because, you know, there's the only way the emergency medical service paramedic, EMT, or emergency physician can follow a pulse is if they have access to it. And that access could be paper access. There's a paper form at the facility or at the assisted living or in the home that they could see. If they don't have access to it, they don't have doctor's orders that they can identify to limit treatment, then according to EMS protocols around the country, they have to pursue aggressive care, life-saving care. They require a provider order. In some states, a physician order. In other states, Minnesota and North Dakota included, it's a provider order, which is, you know, a POST form, provider order for life-sustaining treatment. So they have to see it in order to follow it. And if it's, you know, the patient, the paramedic, the spouse or the adult child may tell the paramedic, you know, mom didn't want this. Well, they can't follow that. I mean, they're not allowed to follow a verbal order from even a spouse. What they have to have is a provider order to do this. So I would say that the best thing would be, if you were is to always have that POST available. It's easy if the patient's in the home or in the facility. If you take them out, it's probably a good idea to take a copy of the form with you if there's concerns about an event happening, so it could be shown to EMS when they present.
I encourage family members to have their little packet that they either send with the person that's a caregiver that's going out, or that they take with them every time, that has pertinent information like that, so it's readily available. It's part of that crisis preparation that you need to make. Otherwise, those desires or those wishes go to a heroic method. So just have your little travel packet with you.
Good idea.
I'm married to a firefighter paramedic, and that has been a topic of discussion at our dinner table more than once. But it's also created a situation where I recognize that as everyone comes on to hospice, or even when we go out to do a referral, if they don't come on to hospice, we have a little sort of plastic, kind of half-page size envelope with a magnet on it that is stuck to their fridge, and it's got their POST and a couple other things. And I tell them, every time you leave, if you leave, take this envelope with you, and they throw it in their purse, and it's kind of red, and it says POST on it, so that when EMS arrives, they know exactly what to look for, and it's readily available.
So another question that came through was, how much do you share with a loved one when they're in the moderate stages and no longer believe that they have Alzheimer's?
I think the first thing to determine is whether the patient has capacity to make the decision. To what degree? I mean, and that's a physician determination. That's what physicians are empowered to do, is to determine mental capacity. If the person has adequate cognition and judgment to make informed decisions. Usually that's done informally when if a doctor simply can sit down with a patient and see if the patient can dialogue about their medical history and seems to respond with cogent answers to questions about medical history and about their wishes. And so a patient has to be able to have an understanding of and be able to dialogue about these issues to demonstrate that they have capacity. If there is a question about capacity that's more complicated than a family physician or an internist can handle, because there's a great deal of uncertainty, maybe because there's superimposed mental health issues with history of schizophrenia or something like that, then sometimes a psychiatrist is occasionally brought in. But most of the time, a family physician or internist or palliative care doctor can make this determination whether or not the patient has capacity. If they don't, then the decision maker becomes whoever they select as their healthcare agent. If they haven't selected them, then according to North Dakota statute, it's usually next of kin, spouse, and adult children, and so on. And let me just say that people may not have the ability to make medical decisions, because discussing CPR or what hospitalization might entail can be very nuanced and difficult for a patient with dementia to understand, even sometimes in milder stages of dementia. But they may have very good ability to select a surrogate still at that point, particularly if they have mild or moderate dementia. So they could be asked, if you're not able to make decisions, who do you trust to make decisions for you? Do you trust your wife, Martha, to make decisions, or do you trust your daughter, Susan, to make decisions? So they may be, and if they can say that and say that consistently, then they can name a surrogate to make decisions for them. And then the surrogate would become, the entitled decision maker at that point in time.
I'll just chime in here and say simply, talk early, talk early, talk early, talk early, talk early. Don't wait. And the reason is that by the time a person is in the mid stages, even if you look at a MoCA score, a SLUMS mini mental or whatever, that's going to give you a clue. And keep in mind, they're on a progressive, regressive journey. So you're all of a sudden talking to them about their end of life, and in their head, they think they're 35. And so why would a 35-year-old be talking to you about the end of their life? They got a lot of time to think about this. So that's why you need to reach out to the professionals at that point and say, okay, help me. If you're waiting for consent from that person, you're probably never going to get it. I just hate to be that discouraging. Start to take other steps.
And I want to say also that when people have mild dementia, early stages of Alzheimer's or other forms of dementia, they still may have decision-making ability. And I reflect back on the interaction that I had with my father when I had him go into an assisted living apartment when he was no longer able to manage any longer at home. And a lot of things, Scott, you said in your presentation really resonated with moving someone at that point in time and how to do that appropriately. And I have to say that my wife and I did a very good job. And he was very accepting, and it went well. But anyway, he was required to make a decision, or a decision needed to be made, as most assisted living and skilled nursing facilities for sure have policies where they want to have a code status determination, because they want to know what to do if somebody is found down. Do they initiate CPR, and what is EMT directed to do? So I asked my father, and again, he was diagnosed with Alzheimer's disease, but he was able to dialogue. And I simply had the conversation with him, Dad, if your heart stopped, there's a treatment for that doesn't work very well, but the doctors and the paramedics could try it, called CPR on chest, where they do chest compressions. If you remember seeing that on TV, and he did. And I said, would you want that done? And he says, He said, I'm 84 years old. If my heart stops, I'm ready to go. I don't want anything like that done. And I went on and discussed intubation with him and explained that. And he had the same reaction. No, if I'm that sick, it's time for me to go. I don't want anything like that done. So you shouldn't count, because of a diagnosis of dementia or Alzheimer's disease, you shouldn't say someone has completely lost their decision-making abilities. They may in the earlier stages have the ability to make these straightforward decisions and may understand them. They may not, but they may. And they certainly may have the ability to appoint a surrogate at that point in time. So that's very important to consider.
Yeah, that is one topic that I discuss with families too, is competence and capacity are different. And one's a legal determination and one's a medical judgment. And I mean, they don't have to be able to, do complex tasks like, do their taxes in order to be able to say, no, I want my daughter to make these decisions for me. Now, if you were to ask them, do you want to have surgery for something, I mean, very complex decisions with heavily weighted sort of complex outcomes, yeah, they probably don't have capacity for that. But to say, would you want a feeding tube if you couldn't eat, knowing that, you would gradually starve to death? Okay, that's a bit more straightforward. And there's some nuance to that as well, but that's a much easier decision to make than, the complexities of, bypass surgery and on a vent and, all that kind of stuff. So the kind of decision that has to be made also weighs into that.